Y es un honor y un gran honor y un placer para mí yo presentar a uno de los principales líderes en el campo de las cefaleas, tanto en los Estados Unidos como en el mundo. Y se trata del doctor Stewart Tepper. El doctor profesor Stewart Tepper hizo sus estudios en la Universidad de Yale, donde recibió su doctorado en la Facultad de Medicina de la Universidad de Cornell en New York y se formó en neurología en el programa de Longwood de Harvard en Boston. Él pasó 15 años en Seattle, Washington, en el Hospital Sueco y en el Policlínico como profesor de la Universidad de Washington, Seattle. Posteriormente se unió al profesor Alan Rappaport y al doctor Fred Scheftel como director del New England Center de Stamford, Connecticut, donde tuve la oportunidad de formarme hace muchos años. El doctor Tepper, al dejar Stanford, se mudó a Cleveland Clinic y finalmente labora como profesor de neurología en Geisel School en Vermont y director del Headache Center de Vermont Hitchcock Center. Él ha escrito más de 250 artículos, varios libros sobre el dolor de cabeza y la mayoría adjunto con el doctor Rappaport y Fred Scheftel, que ya no está con nosotros. Él es editor y es revisor de varias revistas. Es expositor muy solicitado en el circuito y en el mundo de los dolores de cabeza. Es un expositor altamente reconocido en los Estados Unidos e internacionalmente por más de 30 años. Adelante, doctor Tepper. Adelante.
I'm going to talk about the pathophysiology of trigeminal autonomic cephalalgias first. I have 2 more talks after that Dr. Robles has asked me to give. These are my disclosures. I work with a lot of industry to create new therapies, but with respect to trigeminal autonomic cephalalgias or TACs, these are the important disclosures, and I work with companies that create medications as well as devices for trigeminal autonomic cephalalgias. There are 4 trigeminal autonomic cephalalgias, which we call TACs: cluster, paroxysmal hemicrania, short-lasting unilateral neuralgiform headache attacks, and hemicrania continua. And this is according to the International Classification of Headache Disorders, 3rd edition, the ICHD-3. And I'll briefly talk about pathophysiology for each one. But first, a case. A 48-year-old man comes to your office complaining of 3 weeks of recurrent headaches, which are extremely severe in the right orbit, in the right teeth, in the right temple, in the right neck. And each headache lasts 45 to 60 minutes and then comes at a rate of 1 to 2 attacks every 24 hours, usually 1 attack within 2 hours of falling asleep. Each headache is associated with right-sided lacrimation, right-sided dislike of light and noise, right ptosis, and intense agitation. He also has a constant low-level discomfort in the right side of the head between the attacks, and he has an alcohol trigger. He has had similar episodes over the past 7 years. Each cycle or bout lasts 6 weeks of daily headache and then spontaneously resolves, and he gets up to 8 months between the cycles. He is a smoker, and in the past he's had normal blood work, normal MRI with and without contrast, normal MRA, and his neurologic examination is normal. Which of the trigeminal autonomic cephalalgias does he have? Does he have paroxysmal hemicrania, or cluster or hemicrania continua? Does he actually have migraine or something else? Well, I'd like to go through this and suggest what his diagnosis is. Cluster headache by ICHD-3 criteria requires that the patient have at least 5 attacks of severe or very severe side-locked attack lasting 15 minutes to 180 minutes, so his 45 minutes fits. The headache should be accompanied by cranial autonomic symptoms on the same side that can include a red eye, a tearing eye, nasal congestion or rhinorrhea, eyelid edema, forehead or facial sweating, and an ipsilateral Horner's with meiosis and or ptosis. And notice that he has the lacrimation and the ptosis, and then a sense of restlessness or agitation. Patient only needs one of those 6, with an attack frequency of every other day to 8 per day, his being 1 to 2 per day, not attributed to another disorder. The ICHD-3 also requires that episodic cluster patients have pain-free remission periods of greater than 3 months per year, so he would fit that as well. Cluster is generated from the ipsilateral posterior hypothalamus, so on the right side for him. And Arnamai and Peter Goatsby did functional imaging that showed this. When the hypothalamic generator is activated, it in turn sends out efferents to the superior salivatory nucleus, and from the superior salivatory nucleus to the sphenopalatine ganglion. The parasympathetics exit the sphenopalatine ganglion and move on to the target organs. Oxygen inhibits the superior salivatory nucleus to sphenopalatine ganglion arm of this outflow. So hypothalamus to superior salivatory nucleus to sphenopalatine ganglion and out. Functional imaging suggests a more complex picture in which increased functional connectivity occurs during cluster between that central generator in the ipsilateral posterior hypothalamus and the ventral tegmental area, dorsal raphe, bilateral substantia nigra, subthalamic nucleus, and red nucleus. These areas modulate midbrain dopamine systems, orexinergic and serotonergic pathways. So it is a little bit more complex than just the simple diagram I first showed you. There is a relationship between CGRP and cluster headache, but it's also somewhat complex. These were studies done at the Copenhagen Headache Center, and they took patients who were in active phase or cycle of their episodic cluster headache and infused calcitonin gene-related peptide, or CGRP, and 8 out of 9 developed a cluster headache attack within 70 minutes. However, during the remission phase, when the patients were not having active headaches, not one of those patients, so this would be in the at least 3 months, and in this patient's case, 8 months where they're not in cycle, not one of those patients developed a cluster headache attack after IV CGRP. Chronic cluster headache patients who never get a day off only develop an attack after CGRP about half the time. So 7 out of 14 chronic cluster patients developed an attack after IV CGRP within an hour. It looks like CGRP plays a role at both nociceptive and parasympathetic ends of the trigeminal autonomic reflex, and it turned out that cluster headache patients with higher attack frequency were more likely to be triggered by CGRP than those with lower attack frequency, at least in episodic cluster headache, not chronic cluster. Let's move on to paroxysmal hemicrania. PH looks just like cluster. except the attacks are shorter, 2 to 30 minutes. Generally, mean is about 13 minutes. And the frequency during the cycles is higher, greater than 5 attacks per day. Different than cluster, paroxysmal hemicrania is prevented absolutely by therapeutic doses of indomethacin. In the ICHD-3, episodic paroxysmal hemicrania requires pain-free periods of at least 3 months. Chronic paroxysmal hemicrania, no remission, no pain-free periods. They have multiple attacks every single day. The paroxysmal hemicrania activation is different than cluster. Cluster is the ipsilateral posterior hypothalamus, paroxysmal hemicrania, the contralateral posterior hypothalamus, as well as the contralateral ventral midbrain extending over the red nucleus and substantia nigra. So despite the fact the attacks look very similar, they are different in functional imaging and in treatment, in that indomethacin works for PH. Hemicrania continua is a unilateral continuous headache which is of moderate or greater intensity and then has the same features as PH and cluster. Again, hemicrania continua responds absolutely to therapeutic doses of indomethacin, unlike cluster. In ICHD-3, a new remitting subtype where the patient does not have headaches for at least 24 hours versus the more common unremitting subtype. Both are called out. But remember that hemicrania continua is continuous one-sided headache with spikes of breakthrough and cranial autonomic symptoms. The intensity of the continuous headache in hemicrania continua is not mild, it's generally moderate or severe. HC shows contralateral hypothalamic activation, such as seen in paroxysmal hemicrania, but ipsilateral midbrain activation. And so you can see that these TACs are different, each one slightly different in what is activated centrally. The last TAC is short-lasting unilateral neuralgiform headaches, SUNHA, which comes in 2 forms: SUNCT, short-lasting unilateral neuralgiform headaches with conjunctival injection and tearing, and SUNA, short-lasting unilateral neuralgiform headache attacks. SUNHA, again, includes the cranial autonomic symptoms seen in the other 3 TACs, but does not include the agitation, which is one of the features that allows for a diagnosis of the other 3 TACs. Attacks of SUNHA are short and frequent, and patients have moderate or severe side-locked unilateral head pain. Again, the same distribution, 1 to 600 seconds, occurring as stabs, series of stabs, or in a sawtooth pattern, with a frequency of at least 1 a day, but with many patients having 40 or 100 attacks in a day. The division between SUNCT and SUNA, which was new in the ICHD-3, is that SUNCT includes both conjunctival injection and lacrimation, while SUNHA includes at least 1 cranial autonomic feature, but not both conjunctival injection and tearing. Episodic SUNHA requires pain-free periods of at least 3 months, chronic, no pain-free periods. And SUNHA is very rare. Because it is so rare, it's worth looking a little bit more at it so you don't miss it when you see it. It looks like trigeminal neuralgia, except that it is generally in the first division of the trigeminal nerve. There are all of those cranial autonomic features, but there can be trigger zones similar to trigeminal neuralgia, and the stabs or group of stabs or sawtooth pattern is characteristic. Again, because TACs are rare, regular MRI with and without contrast is mandatory for diagnosing any of these TACs. Here's the SUNCT functional MRI, bold contrast increasing in the ipsilateral posterior inferior hypothalamus, a bit lower than in cluster. Here are the 4 generators on functional imaging. Cluster, the ipsilateral posterior inferior hypothalamus, paroxysmal hemicrania, the contralateral posterior hypothalamus, and the contralateral midbrain. Hemicrania continua, the contralateral posterior hypothalamus and ipsilateral midbrain, and SUNCT, the ipsilateral posterior inferior hypothalamus, a bit lower than cluster. In this patient's case, the most likely diagnosis is episodic cluster headache, which is probably the most common of all the TACs. Treatments can include transitional treatments such as occipital nerve blocks with an anesthetic and steroid, or an oral steroid pulse while establishing prevention. In the US, 3 treatments are FDA approved for the acute treatment of the attacks: subcutaneous sumatriptan, parenteral dihydroergotamine, and the non-invasive vagal nerve stimulator, which I will show you. Not FDA approved, but with level A evidence, is oxygen, 7 to 15 liters through a non-rebreathing mask for 20 minutes. Nasal zolmitriptan is also approved in Europe. This is the non-invasive vagal nerve stimulator, which is FDA cleared for the acute treatment of episodic cluster headache. It works to terminate episodic cluster headache. It does not work to terminate chronic cluster headache. And 2 randomized controlled trials confirmed exactly that. The treatment is 3 2-minute stimulations external to the vagus. Wait 3 minutes and do 3 more 2-minute stimulations if needed, and up to 4 attacks or 24 stimulations in a day. There are not significant adverse events with the device, which causes the ipsilateral lip to twitch when it's activated. The biggest problem with getting this device for patients is cost and coverage, but it does work to terminate cluster without oxygen or triptans. On the preventive side, for the first time in the United States, we have an FDA-approved medication for preventing episodic cluster headache, galcanezumab. The vagal nerve stimulator is also FDA cleared for prevention of cluster headache as an adjunctive treatment on top of the other treatments, whether those be verapamil, an anti-epilepsy drug, lithium, methylergonovine, or galcanezumab. The non-invasive vagal nerve stimulator is approved for prevention of both kinds of cluster, episodic and chronic. The galcanezumab trial for the prevention of episodic cluster headache was extremely important. It was very much highlighted in the New England Journal of Medicine. And what it did was take patients who had a baseline of 17 cluster headache attacks per week and reduce that to about 9 attacks per week. 17 attacks per week means that the patients are having between 2 and 3 attacks per day. The dosage was 300 milligrams subcutaneous monthly in a pre-filled syringe, 3 injections across the abdomen monthly until the cycle ends. The 50% responder rates were also positive. However, galcanezumab was not effective in preventing chronic cluster headache, and fremanezumab was not effective in its studies in preventing either episodic or chronic cluster headache. And the question on these other studies is whether the methodology was problematic or whether, in fact, galcanezumab has unique properties in preventing episodic cluster headache. Still, it's being used widely in the United States now for the prevention of cluster. The other TAC treatments are not FDA approved. paroxysmal hemicrania, and HC require indomethacin. SUNHA requires anti-epilepsy drugs, lamotrigine, gabapentin, carbamazepine, or oxcarbazepine. In the indomethacin responsive tacs, when indomethacin cannot be used, depending on the reason, you can consider using other non-steroidal anti-inflammatories, AEDs, verapamil, or even melatonin. So in summary, there are 4 trigeminal autonomic cephalalgias: cluster, paroxysmal hemicrania, hemicrania continua, and SUNHA, each coming in episodic and chronic forms. Workup is mandatory with an MRI with and without contrast, an MRA if you can get it, and you're looking for sellar and posterior fossa lesions, which can cause secondary tacs. Each of the tacs has different pathophysiology with different functional imaging data for the central generators. At least episodic cluster headache has a CGRP biology, not so clear for chronic cluster. Cluster now has 2 FDA-approved preventive treatments: non-invasive vagal nerve stimulation adjunctively for all types of cluster, and galcanezumab for the prevention of episodic cluster. Cluster has sumatriptan, dihydroergotamine, and non-invasive vagal nerve stimulation FDA approved for acute treatment, and PH and HC are the indomethacin responsive trigeminal autonomic cephalalgias. Thank you. I'm going to take a second and move on to the next talk.